Welcome to the topic Megaloblastic Anemia. Very interesting topic. Remember, my friends, the synthesis of nucleus and the DNA in the nucleus that requires raw materials, mainly it's the vitamin B12 and the folic acid. They are the one which will act as a raw material for synthesis of the DNA that is there in the nucleus. So if you don't supply these raw materials, then a person can suffer from variety of disorders. What is manifested with in peripheral blood is the megaloblastic anemia. As such, when you use the word megaloblastic anemia, it's the bone marrow finding. Yes, you will not see megaloblast in the peripheral blood. What we see in the peripheral blood is the macrocytic RBC. So we call it as macrocytic anemia. Remember, macrocytic anemia is the peripheral blood finding, whereas megaloblastic anemia is the bone marrow finding. There are so many other causes for macrocytic anemia as well. So let us have a look on this very interesting topic, megaloblastic anemia. I'm not going in detail about the other macrocytic anemias. But remember, the macrocytic anemias are classified as two headings, macrocytic anemias but not megaloblastic. That means if you do bone marrow examination, you will not see the megaloblast. What you will see is in peripheral blood you will see macrocytes, in bone marrow you will see the normoblast. So what are the causes? It could be due to the liver cell disorders. Patient having the liver disorders, then chronic alcoholism patients, they can have only macrocytic anemia, or patient with the aplastic anemia. So aplastic anemia is one of the important cause for the pancytopenia. When you use the word pancytopenia, it is reduced red cell mass manifested by reduced hemoglobin percentage, reduced WBCs, and platelets will be reduced. So all the three cell lineages, RBC, WBC, platelets, all the three will be reduced. Then we will call it as pancytopenia. So important cause for pancytopenia is the aplastic anemia. But in developing countries like in India, megaloblastic anemia is the most common cause for pancytopenia. Macrocytic but megaloblastic anemia. That means in peripheral blood you will see macrocytes, not only macrocytes, macroovulocytes, which are very classical for the megaloblastic anemia. You will see in the peripheral blood, and same patient when you do the bone marrow examination, you will see megaloblastic erythroid hyperplasia. So causes are mainly due to the combined deficiency of vitamin B12 and the folic acid. So what is this megaloblast as such? So remember, in the erythropoiesis, the precursor cells are called as erythroblast. So proerythroblast, right? So that will mature into the early, intermediate and late normoblast. So the late normoblast will give rise to the polychromatophilic cells, that is reticulocytes, what we call, right? So that will give rise to the mature RBCs. This erythroid precursors, if they are larger in size, then we call it as megaloblast. So we will see them in the megaloblastic anemia. So it is nothing but, normoblast is nothing but a precursor of the normal RBC, whereas megaloblast is nothing but a precursor of the macrocytic RBC. The normal DNA maturation will be there for the normoblast, whereas the DNA maturation is the one which is hampered in megaloblastic anemia. Remember, the cytoplasmic maturation will be absolutely normal in the megaloblast. So it's only the DNA maturation is get affected. Hemoglobinization is normal. That's why you will see normal hemoglobinization cytoplasm in the cytoplasm of the megaloblast. It is only the DNA which is get maturation delayed. So we call it as lagging behind of nuclear maturation as compared to the cytoplasmic maturation. Here also we have early, intermediate and late normoblast, and megaloblast also we have three types: early, intermediate and late megaloblasts. So this is a point you need to remember. There is a delayed nuclear maturation, whereas hemoglobin synthesis is not affected because it is not due to iron deficiency. It is due to the deficiency of the raw materials required for DNA maturation, that is the vitamin B12 as well as the folic acid. So if there is iron deficiency is not there, then patient will have a megaloblastic type of anemia. If he is having also the iron deficiency, then patient will have a dimorphic anemia, both microcytic hypochromic as well as macrocytic anemia. So with that, let us have a look on the megaloblastic anemia. What are the causes and what are the findings? What are the etiological factor for the megaloblastic anemia? Remember, megaloblastic anemia due to vitamin butyl deficiency singly, or it could be due to the vitamin folic acid deficiency, or most of the time it is combined deficiency. That's the one which usually occurs in the megaloblastic anemia. But independently, deficiency of vitamin butyl and folic acid can also cause the megaloblastic changes. What are the causes for vitamin butyl deficiency? It could be the decreased intake itself. Especially the pure vegetarians, they are very much prone for development of the vitamin butyl. If at all they don't take green leafy vegetables in adequate quantity, then invariably they suffer from vitamin butyl deficiency. It could be due to the impaired absorption. One of the important cause is the pernicious anemia. What is this pernicious anemia? These patients will have a circulating anti-intrinsic factor antibodies, or these patients have no secretion of intrinsic factor itself. So remember, intrinsic factor is required again for proper absorption of the vitamin butyl from the enterocytes of the ileum. So if that is not there, again these patients will have a development of the megaloblastic anemia. So patient whoever has undergone gastrectomy, because intrinsic factor is mainly synthesized and secreted by the parietal cells of the stomach, so they also can suffer from megaloblastic anemia. Malabsorption syndromes, especially it is the intestinal disorders, because it is the terminal ileum where the vitamin butyl is get absorbed as such. So any patient who has undergone ileal resection, so they can suffer from the megaloblastic anemias. One of the worm infestation, we call it as fish tapeworm infection or Diphalobothrium latum, that can also cause the megaloblastic anemias. Bacterial overgrowth syndromes, like what we call it as blind loop syndromes. Pregnancy, again there is a high requirement. If you don't supply, again they can suffer from megaloblastic anemias. Hyperthyroidism patients, they will have increased catabolic rates, metabolism will be more. So that's why these patients again can have a megaloblastic anemias, and even patient with a cancer. Especially if they are on anti-folate drugs, they are very susceptible for megaloblastic anemias and anti-folate drugs. So these are the causes for folic acid deficiency. So especially it's the cancer patients who are an anti-folate, folic acid antagonists, they can have a folic acid deficiency. But remember, folic acid deficiency is very, very common in alcoholics. So alcoholics will suffer from, chronic alcoholics will suffer from folic acid deficiency, which can in turn lead to the megaloblastic anemia. Infants again need to be supplemented with the folic acid. If you don't supplement folic acid, they can also suffer from megaloblastic anemia. Again, malabsorption syndrome, intestinal disorders, drugs, increased loss like hemodialysis patients, pregnancy, infancy, and various cancers. These patients can have a folic acid deficiencies. So most of the time it is the deficiency of both vitamin butyl as well as the folic acid. So what will happen? The DNA synthesis get affected. The nuclear maturation doesn't happen. Nucleus remains immature. So such cells will undergo lesser and lesser division, and the cells will become more bigger and bigger. We call it as macrocytic cells. So megaloblast, such a megaloblast, they are very much unstable. They are very much abnormal. They will undergo destruction within the bone marrow itself. So we call it as ineffective erythropoiesis, because megaloblasts which are formed in the bone marrow, they get lysed in the bone marrow itself. Understood? That's why the patient with the megaloblastic anemia will have a light jaundice. We call the skin color as lemon yellow colored skin. It is all because of the slightly increased levels of the bilirubin serum levels in patient with the megaloblastic anemia. Remember, megaloblasts, they will not form the effective or mature RBCs, so they results in formation of the macrocytes. Most of the time these megaloblasts will die in the bone marrow itself. So we call it as ineffective erythropoiesis. And it is not only the erythroid series is get affected, it is the DNA which is hampered, right? So DNA of which cell? DNA of all cells in the body. That's why it is all cell lineages are get affected. So RBCs, WBCs, platelets. So patient can have a pancytopenia. So that is peripheral blood. All the three cell lineages can be get affected. So in developing countries, most common cause for pancytopenia is the megaloblastic anemia. So it is a multi-system disease. Remember, megaloblastic anemia patients will have a multi-system disease. All the cells which will contain the nucleus are get hampered, right? So it is increased cell division. All the epithelial cells will be get hampered. So patient can have a variety of other system manifestations also. Remember, one of the cause for megaloblastic anemia is the pernicious anemia. It's a peculiar type of megaloblastic anemia where patient will have a autoimmune disease. Patient will have anti-parietal cell antibodies. They will have anti-intrinsic factor antibodies, and vitamin B12 absorption will become deficient. Mainly, it could be even due to the gastric atrophy. That's why the patient will have inadequate intrinsic factor synthesis itself is get affected. Mainly, patient will have a gastric atrophy. Remember, this chart is very important. Why we have to know in detail about the megaloblastic anemia. So remember, DNA synthesis requires two important raw materials, that is vitamin B12, we call it as cobalamin, and folic acid. Folic acid is tetrahydrofolate, is a form of a folic acid. So methylcobalamin will be converted, cobalamin will be converted into methylcobalamin in the same reaction with the help of the methionine synthesis. N5-methyl tetrahydrofolate will be converted into tetrahydrofolate. Then it will become N510 methylene tetrahydrofolic acid. So it is immediately required for the conversion of diuredyl monophosphate into dithymidine monophosphate. So what is this DTMP? This is immediate precursor of a DNA. So this is the one which requires the help of the cobalamin as well as the folic acid. So that's what happens in the patient with the megaloblastic anemia. With the deficiency of vitamin B12 or cobalamin and with the folic acid, so the DNA maturation is get hampered. Vitamin B12 deficiency, it also causes the demyelination of the peripheral nerves as well as even the spinal cord. We call it as subacute combined degeneration of the spinal cord. So this is what happens in patient with the pernicious anemia. It's one of the autoimmune disorders where patient will have atrophic gastritis. See, this is normal how the gastric epithelium will appear. It is the parietal cells which will secrete the intrinsic factor that even stomach also is capable of secreting acid. So this is how the normal gastric parietal cells will appear. So these patients with pernicious anemia, they will have a atrophic gastritis. They will also have a chlorhydria, and there is no secretion of the intrinsic factor. So let us have the look on how actually the vitamin B12 metabolism will take place in the body. So vitamin B12 absorption and its metabolism. Remember, in the diet, the vitamin B12 will be binded to the proteinous molecules, so it's not easily absorbable directly. So we have a salivary gland molecules, so called as we call them as R binders. So they are the one which will bring this particular complex into the stomach. They will combine and they will bring it to the stomach. In the pepsin that will be there in the stomach, it breaks down this particular diet and it frees it. It makes the vitamin B12 free from the this particular protein bound complex. Then this R binder will bind and they form the so-called as R-B12 complex in the stomach. There is parietal cells in the body which will secrete the intrinsic factor. But remember, intrinsic factor does not bind directly to the vitamin B12 at this particular point. So in the stomach, so it is a R binder that is secreted by the salivary gland will bind to the B12 molecule that is present in the diet. So what will happen further is we have a pancreatic variety of enzymes, mainly proteases. So this particular complex will come to the stomach, it will come to the duodenum. So here in the second portion of a duodenum, there is secretion of the pancreatic proteases. They will make this particular complex to broken down. Then only the vitamin B12 becomes in a free form. Then it will bind to the intrinsic factor. That what happens in almost in the first portion of the jejunum. So intrinsic factor and B12 complex is formed in the first portions of the jejunum. Then this particular complex will move to the ileum. So in the ileal enterocytes, we have a receptors. Over the ileocytes, we have a receptors for the folic acid, intrinsic factor. We have a receptor for the intrinsic factor. So this particular complex, intrinsic factor and B12 complex will come and bind to the ileal enterocytes because they have a receptors. So what happens once they bind, they will get absorbed and then the intrinsic factor will be released and it will be reutilized again by the body for again the same steps will recur. And now the B complex is in a free form, then it binds to the transport molecule, transcobalamin 2. That's the one which will carries to the portal vein. Then it will be B12 will be used. It will be stored in the liver and it will be used for the hematopoiesis. So this is how the vitamin B12 absorption and metabolism will take place. So let us have a look on the how the patient with the peripheral smear, what will be the finding of megaloblastic anemia patients in a peripheral blood smear. Remember, most importantly, they will manifest with the pancytopenia, that is reduced hemoglobin percentage, RBC count will be reduced, total RBC mass will be reduced, and all other parameters will be reduced. HB will be reduced, PC will be reduced. MCV, mean corpuscular volume, is the only parameter that will be raised, whereas MCH and MCH will be remain normal. So how the RBCs will appear? Let us have a look on this diagram. So peripheral blood examination of a patient with a megaloblastic anemia, macrocytic anemia. So normal RBCs will be like this. So they will have a central pallor, central 1/3 of a pallor. We always compare the normal RBC with that of a small non-reactive lymphocyte nucleus. So the size of the nucleus of a small lymphocyte is equal to that of a normal RBC. So that's the internal control in the peripheral blood. So what will happen in the megaloblastic anemia? So we keep on seeing the RBCs which are very, very large in size. So MCV, mean corpuscular volume, normal is, for normal RBC it is 76 to 96 femtoliters. Whereas to call it as macrocytic anemia, we need a mean corpuscular volume more than 100 femtoliters. So usually we see 110, 120 femtoliters in a well-established case of the megaloblastic anemias. So these RBCs are not only macrocytic, they are also macroovocytic. So these macrooovocytes are more important for diagnosing the megaloblastic anemia. Remember, if it is only macrocytic anemia, you have to think about liver disorders and or the aplastic anemias. If it is macroovocytic, you have to think about the megaloblastic anemias. So macroovocytes will not have any central pallor. So they appear as if hyperchromic, but we will never use the word hyperchromia for these RBCs. So MCH will be normal or slightly it will be one more in cases of the megaloblastic anemias. So that is a finding in the RBCs. RBCs are macrocytic and even macroovocytic. Second is the WBC count. So total WBC count can be less. They can have a leukopenia. But what is most important finding is the presence of hypersegmented neutrophil. What is the normal nuclear lobe count? It is around 2 to 5. We call it as Arnith count. ARNITH, Arnith count for the that is counting of the nuclear lobes in the neutrophils. On an average, it will be 3. So 2 to 5 nuclear lobes will be normal for the neutrophils. Any neutrophil which is 6-lobed, we call it as hypersegmented neutrophil. And if you see even single neutrophil with a 6 nuclear lobes, it is a hypersegmented neutrophil that indicates patient might be having megaloblastic anemia. So usually we may see around 8 lobes, 10 lobes. So I have to count these nuclear lobes. 1, 2, 3, 4, 5, 6, 7, 8, 9, so 10. So like that. Hyper segmented. So this is multi-segmented neutrophils you will see in the megaloblastic anemias very classically. So there can be associated thrombocytic anemia can be there in the patient with the megaloblastic anemia. So this is peripheral smear finding in the patient with the megaloblastic anemia. So along with that, you may see the polychromatophilic RBCs that indicates that the bone marrow is responding for the peripheral anemia. You may see the RBC remnants, we call them as hinge bodies. There are so many RBC inclusions, hinge bodies, Pappenheimer bodies, then even the Cabot rings. So you have to read about those RBC inclusions. So they are very commonly asked in the in the MCQs. Hinge bodies are seen in the megaloblastic anemia, also in the hereditary spherocytosis. So WBC will be either normal or will be reduced in number. So it will be less than 4,000. Then hypersegmented neutrophil you have to see at least one hypersegmented neutrophil you have to see to call it as macrocytic anemia belonging to the megaloblastic series. So platelet count may be normal or in severe cases it will be reduced. Overall patient can have a pancytopenia like appearance. So in peripheral blood we will not give it as megaloblastic anemia. We give the report as macrocytic anemia. So we don't comment on the chromia. Remember, we will not call it as macrocytic hyperchromic anemia. No, only macrocytic anemia. We will not comment on the chromia. We comment only on the size. macrocytic anemia. Never use the word hyperchromic like that for the RBCs. You cannot overfill the RBC as such. So macrocytic anemia is the report for these patients. Same patient, once you do the bone marrow aspiration, then only you can see the megaloblast. So what is this? This is macroovalocytes. You see the RBCs are very, very large and they are also showing ovalocytic change. And hypersegmented, it is hypersegmented neutrophils. So anemia will be there can be associated leukopenia will be there can be even thrombocytopenia. So most of the time they will manifest with the pancytopenias. Remember what are the parameters, what will happen to the parameters? Hemoglobin will be less, RBC will be less, packed cell volume will be less. What is the most important for diagnosing megaloblastic anemia is serum estimation of the vitamin butyl levels and serum estimation of the folic acid levels. So they will be invariably reduced. The most important parameter we will look in the hematology analyzer paper is the MCV, that is mean corpuscular volume, should be more than 100 femtoliters to call it as macrocytic anemia. MCH and MCH will be remain normal in patient with the megaloblastic anemia. So if at all you do the bone marrow aspiration, what you will see is these megaloblasts. So these are the beautiful cells which are having a sieved appearance of a chromatin, deep blue cytoplasm, and there will be erythroid hyperplasia. Now patient will have a erythroid hyperplasia. Overall bone marrow cellularity will be more. If you see the fat content, the cells will be more. Normally it will be 50-50, cells to fat ratio is 50-50, but in erythroid hyperplasia or hypercellular marrow, the cells will be more, fat appears less. So there will be erythroid hyperplasia predominantly composed of these megaloblasts. Myeloid to erythroid ratio, normal ratio, it is 3:15:1. So that is myeloid will be more, but here it will be almost 1:1 or sometimes even 1:2. That indicates that there is a erythroid hyperplasia. So what you will see is predominantly the megaloblast. So these are nothing but erythroblasts which are larger in size. They will have an open chromatin, sieved appearance of a chromatin. Have a look at this diagram. So these are the megaloblast. So they will have a open chromatin or a sieved appearance of a chromatin, deep blue cytoplasm. So these are called as megaloblasts. So there will be plenty in a megaloblastic anemia bone marrow aspiration. So along with that we will have a giant metamyelocytes. So this is one more finding in the WBC series. So this is megaloblast, this is giant metamyelocyte. One more interesting finding in the bone marrow aspiration in a patient with a megaloblastic anemia, and that will be asked as a MCQ for you. Giant metamyelocytes are seen in which of the following conditions? Yes, remember my friends, what is the important diagnostic test in a chapter of hematology? So hemoglobin electrophoresis is required for congenital hemolytic anemias. This I will tell in the next topic about hemolytic anemias. Reticulocyte count is again very important for hemolytic anemia diagnosis. Stool for occult blood is required to diagnose the parasitic infestation that are causing either iron deficiency anemia or megaloblastic anemia. Yes, bone marrow aspiration is the mandatory test for diagnosing megaloblastic anemia. Yes, you have to do the bone marrow aspiration to look for these megaloblast. And the test of diagnosis for hereditary spherocytosis is known as osmotic fragility test. So based on these, the MCQs can be framed. One of the outdated test but still important from exam point of view is known as Schilling test, is the test for the pernicious anemia. So here they will do in the 3 parts. In first portion they will give radioactive cyanocobalamin which is given orally, and unlabeled cyanocobalamin is given intramuscularly, and then they keep on collecting the urine sample and measure the radioactive cobalamin content. Whereas in the second test it is performed in the same manner except that intrinsic factor is given orally along with the radioactive cyanocobalamin. In the third portion the patient is treated with the antibiotics priorly. For example, if the patient is having blind lobe syndrome, then again they will estimate the urine sample. So, but what is the problem with this particular test is the inadequate collection of urine sample. So, if you don't correct it properly, you may interpret it in a very wrong way. So, how to diagnose pernicious anemia based on the Schilling test? Abnormal Schilling test, but with improvement in the second test. That is, if you give intrinsic factor, then there will be improvement. So that indicates that patient is having intrinsic factor deficiency and patient is having pernicious anemia. So low levels of serum vitamin B12. So nowadays we will not do Schilling test much. So we will send the blood sample for simple test like vitamin B12 estimation and folic acid estimation, that is enough to diagnose the pernicious anemias. Whereas the folic acid levels will be raised. This is how you have to differentiate from the other megaloblastic anemia, pernicious anemia and megaloblastic anemia. How you can differentiate is the B12 levels will be less, but normal or elevated levels of serum folic acid. So that's how you can differentiate pernicious from anemia from the other causes of the megaloblastic anemias. And you have to also document the chlorhydria. So nowadays, the serum estimation of the intrinsic factor antibodies. So this have totally replaced the Schilling test. So till now we have not done any Schilling test. We are doing this particular test, that serum anti-intrinsic factor antibodies, so that itself proves that patient is having pernicious anemia. So pernicious anemia patient can have mild to moderate or sometimes even severe megaloblastic anemias. Patient can also have leukopenia, and hypersegmented neutrophils can be also seen with the pernicious anemia. And once you treat, the response will be very good. There will be a dramatic reticulocyte response for the treatment as such. It is not so uncommon, especially in Indian setup or in any developing countries, to see dimorphic anemia. Remember, my friends, when to use the word dimorphic. When you see almost equal proportion of microcytes and macrocytes, it is a dimorphic anemia. That is, you will see both microcytes as well as macrocytes. Have a look on this diagram. Here there are microcytic RBCs and also we have macrocytic RBCs. So when you see almost in equal proportion, so it indicates that patient is having nutritional anemia. That is, deficiency of iron is there, deficiency of B12 is there, deficiency of folic acid is there. So once you start giving your treatment with the hematinics, so naturally this anemia will improve. So with that, let us have a look on the important one more topic, that is hemolytic anemias, in the next presentation.